So the first medication antibiotic that we're going to look at class is the penicillins. Penicillins are, you can have the natural penicillins, which include penicillin G, bicillin, which is given intramuscularly, and penicillin V. You can also have the immunopenicillins, which include second generation, which are active against gram-positive bacilli. These include the ampicillin, amoxicillin with potassium clavulate or augmentin, and ampicillin/sulbactam. You can also have the penicillinase-resistant penicillins. These are the anti-staphylococci or coccopenicillins. These are active against the penicillinase-producing staphylococci, and these include the dicloxacillin, methicillin, and oxacillin. You can have the carboxypenicillins, which are third generation and are anti-pseudomonal penicillins. These are the ticarcillin and ticarcillin with clavulate. And finally, you can have the uridopenicillins, which are fourth generations. These are anti-pseudomonal penicillins as well. This is the piperacillin sodium and tazobactam sodium. So what are the indications of the penicillins? These are frequently used for otitis media, streptococcal pharyngitis, sinusitis, pneumococcal pneumonia, urinary tract infections in pregnancy, animal bites, impetigo, syphilis, as well as gonorrhea. Allergies, the incidence of penicillin allergy is unknown, but it's probably between 5 and 10%. Life-threatening anaphylaxis is estimated at 0.01% to 0.05%. There is a cross-reactivity to the carbapenems, and therefore carbapenem may not be a reasonable choice for penicillin allergic patients. They may also be allergic to the cephalosporins. If the patient is allergic to penicillin, you want to avoid the beta-lactam antibiotics. Well, what is the resistance in our penicillin? Microbial resistance to the penicillins are now common and has been a major limitation to their use. The resistance of bacteria to penicillins and other beta-lactam antibiotics occur through three mechanisms. First mechanism is the bacteria producing beta-lactamase. This breaks down the beta-lactam ring and renders the penicillin inactive. Staphylococcus aureus is one of the most important of these organisms. The methicillin-resistant Staphylococcus aureus, or MRSA, is now resistant to most antibiotics and is very difficult to treat. Methicillin is no longer marketed in the United States because of this resistance as well as the toxicity. The inhibitors of the beta-lactamase, such as clavulanic acid, sulbactam, and tazobactam, often are used in combination with certain penicillins to prevent their inactivation. The second mechanism of resistance is by way of a diminished permeability of the drug through the bacterial outer cell membrane. The antibiotic is unable to penetrate the cell wall, especially in those gram-negative bacteria. The last mechanism involves decreasing binding of the drug at its target site on the inner bacterial membrane. These three mechanisms have led to a significant resistance in penicillin medications. So what is the mechanism of action? Penicillins, which are bactericidal against they're susceptible organisms, disrupt the synthesis of the bacterial cell wall, and compete for the binding to specific enzyme proteins that catalyze transpeptidation and cross-linking. The enzymes to which they bind are called penicillin binding proteins. This action interferes with the biosynthesis of mucopeptides and prevents the linkage of structural components of the cell wall. So in other words, it disrupts the synthesis of the cell wall. After the penicillin molecules bind and inhibit the transpeptase enzymes, susceptible bacteria are no longer able to lay protein crosslinks across the peptoglycan backbone of the cell wall. In addition to being structurally weak, this formation is thought to catalyze the activation of autolytic enzymes in the cell wall that cause progressive bacterial lysis. So what are the treatment principles? Penicillins are indicated for mild to moderately severe infections. They're also indicated for empirical treatment for many infections according to the site of the infection, and in some cases while the results of a culture is pending. Usually the treatment duration of penicillin is 10 to 14 days. So what type of patient variables affect the use of penicillins? Well, for geriatric patients, oral penicillins are generally well tolerated. The high sodium content of certain parental penicillin may pose a danger for patients with cardiac and renal conditions in the elderly. For pediatrics, for infants younger than 3 months, you must investigate the history of a penicillin allergy in the mother. Often these infants will also have a penicillin allergy if their mother is penicillin allergic. Pediatric renal tubular function appears to be mature more slowly than the GMR and reaches adult levels at approximately 7.5 to 8 months of age. Since penicillins are secreted by the renal tubules, the clearance is reduced at birth, but appears to increase swiftly during the child's first year of life. This is why many of the children greater than 3 months old of age are treated with amoxicillin for ear infections. For women who are pregnant and lactating, it is considered a category B. There's been no adequate studies, but use in pregnancy is acceptable only if clearly needed. The penicillin does cross the placenta and is excreted in breast milk. It can cause diarrhea, yeast infections, or allergic responses in the nursing infant. Also, it's been found that the use of penicillin in nursing mothers may lead to sensitizing of infants to penicillin. So we need to be pretty selective of who we treat with penicillin when the mother is nursing or pregnant. For women who are taking mostly ampicillin and penicillin V, should be educated about the use of alternative methods of contraception if they are using estrogen-containing contraceptives, since the effectiveness is believed to be compromised during antibiotic usage. And patient education. Patients should take most penicillins on an empty stomach 1 hour before, 2 hours after a meal, with a full glass of water. Penicillin V may be given with meals, although the drug level may be higher when given on an empty stomach. Ampicillin should be given on an empty stomach to enhance absorption. Ampicillin may be given without regard to meals. However, augmentin is best given with a meal to minimize GI upsets. Patients should notify their provider if a rash, itching, hives, severe diarrhea, shortness of breath, urticaria, black tongue, sore throat, nausea, vomiting, fever, swollen joints, or any unusual bleeding or bruising occurs with the use of penicillin. Those patients with penicillin allergies or hypersensitivity should be urged to wear some type of emergency identification to inform others of their allergy, and patient members or family members should report any symptoms that suggest a developing allergic reaction. Intradermal skin tests may detect previous drug sensitivities in these patients. Penicillin tablets should be stored at 15 to 30 degrees Celsius or 59 to 86 degrees Fahrenheit, and solutions remain stable for 14 days when refrigerated. That's very important for the pediatric patients who often receive amoxicillin, which is mixed. It is only stable for 14 days and should be thrown away thereafter. We'll move on now to cephalosporins. Cephalosporins have first, second, third generations, as well as a fourth generation. First generation cephalosporins include medications like Keflex or Duracef. The second generations include medications such as Cefzil, C-Chlor, Viantin, Ceftin, and Lorabid. The third generations include Suprex, Rosefin, which is given IM or IV, Omnicef, and the fourth generations include Cefapine. There is a fifth generation which is very rarely used, which is the Ceftaroline. All cephalosporins are active against most gram-positive cocci, such as Staphylococcus aureus, and many strains of gram-negative bacteria, such as E. coli. The first generation drugs are usually used for skin and soft tissues, as well as urinary tract infections. Second and third generation cephalosporins are often used for otitis media, gonorrhea, acute bronchitis or pneumonia in patients with COPD, community-acquired pneumonia, pharyngitis, sinusitis, and Lyme disease. Fourth generation drugs are mostly used in the inpatient settings. This is for bacteremia, community-acquired pneumonia, intra-abdominal infections, pneumonia, and pyelonephritis urinary tract infections. Fifth generations is only a parental product that is active against gram-positive pathogens, including the methicillin-resistant Staph aureus, vancomycin-resistant Staph aureus, vancomycin-insensitive Staph aureus, and hetero-resistant vancomycin-insensitive Staph aureus. It is used for acute bacterial skin and skin structure infections and a community-acquired pneumonia. It is not commonly used in the primary care settings. Allergies. It is believed that many individuals with a true penicillin allergy may also be allergic to the cephalosporins. However, less than 5% of the patients with a positive skin test for penicillin will react to cephalosporins. So you need to keep this in mind. Cephalosporins can be used in patients with penicillin allergies, but there is still a 5% chance. Resistance has developed easily because of the broad spectrum effect of cephalosporins. The general mechanism of resistance has been identified, the same ones as for penicillin. The most common mechanism of resistance to cephalosporin is the destruction by hydrolysis of the beta-lactam ring by beta-lactamase. Also important is the ability of the drug to penetrate the walls of the bacteria. If the drug can penetrate quickly, less of the drug is broken down by the beta-lactamase. Cephalosporin-resistant gonococci has increased significantly in the past 10 years. The event of some semi-synthetic products may help these drugs with resistance to bacteria. However, that needs to be developed. So what is the mechanism of action? Cephalosporins are beta-lactam antibiotics that have the ability to resist bacterial enzymes, specifically the beta-lactamase. They have a similar mechanism of action to that of penicillin, in which they interfere with the cell wall synthesis through inhibition of the synthesis of the bacterial peptoglycan in the cell wall. The antibiotic then binds to the enzymes that build and maintain that cell wall. This makes the cell wall osmotically unstable. Cephalosporins are bactericidal and usually are effective against rapidly growing organisms. They differ in terms of which enzymes they affect. Their spectrum of activity, the first generations are mostly active against gram-positive organisms. The second generations are largely gram-positive and are active against some gram-negatives. Third generations are active against gram-positive and mostly gram-negatives. Limitations of cephalosporins, effectiveness: cephalosporins do not exhibit activity against a number of the common organisms, including the penicillin-resistant pneumococcus, methicillin-resistant Staphylococcus aureus, and Staphylococcus epidermidis. Enterococcus, Listeria, Mycoplasma, Clostridia, Campylobacter, Chlamydia pneumonia, and Chlamydia trichomonas. So what are the treatment principles? Again, we have patient variables. In geriatric patients, the products are generally safe and effective. Renally adjusted dosage is based on creatinine clearance, and this may be necessary for those elderly who have a low GFR. In pediatric patients, these products are also generally safe and effective. In neonates, the accumulation of cephalosporins has occurred. However, each cephalosporin has a different age for established safety, ranging usually from 1 to 9 months. Cefaclor, extended release tabs, and cephalexin, cefotetin are not indicated for children. For those pregnant women as well as lactating women, this is considered a category B. Cephalosporins appear to be safe in pregnant patients, but relatively few controlled studies have been conducted. These medications are used only when potential benefits outweigh potential hazards to the fetus. These products do cross the placenta and are excreted in the breast milk. Again, patient education. These medications should be taken with food or milk to prevent GI upset. The patient should notify the provider of any nausea, vomiting, diarrhea, and any response that would suggest an allergic reaction. We'll move on to the tetracyclines. The two tetracyclines seen in primary care are tetracycline and doxycycline. Doxycycline is more commonly used than tetracycline. They are active against a wide range of aerobic and gram-positive, gram-negative bacteria, such as Haemophilus, Yersinia. Most gram-positive bacteria are now resistant to the tetracyclines. These drugs are not the drugs of choice for strep infections or staphylococcus. Their greatest usefulness is against Rickettsia, Mycoplasma, Protozoa, and Chlamydia. These are used for Lyme disease, Rocky Mountain spotted fever. They have few major side effects, except, again, the teeth of children and pregnant women. They can possibly cause diarrhea, which can be a symptom of a superinfection or a side effect. Usually the naturally occurring tetracyclines are short-acting, and the semi-synthetic are intermediate-acting or long-acting. These medications are indicated for Lyme disease, acute exacerbation of COPD, sinusitis for those patients that cannot take penicillins, pneumonia, chlamydia, rickettsial infections such as Lyme disease, as well as Rocky Mountain spotted fever, and sometimes they're used in urinary tract infections. The minocycline microspheres, the tetracycline fiber, and low-dose doxycycline are used as adjunctive treatment in paroiditis. There are unlabeled indications in which D-miclocycline has been unlabeled use in the treatment syndrome of inappropriate antidiuretic hormone. Allergies are not very common in this class of medications. Anaphylaxis, urticaria, periorbital edema, fixed drug eruptions, and rashes may occur. A systemic lupus erythematous rash-like syndrome has been seen along with positive anti-nuclear antibodies in patients who are on tetracyclines. Resistance to tetracycline is plasmid mediated and occurs due to decreased influx into the cell, decreased access to the ribosome, and enzymatic inactivation. Campylobacter and Shigella have become largely resistant, and a total of 15 to 60% of the pneumococci have become resistant. There's no known protozoa, chlamydia, or rickettsia resistance as at this time. All of the tetracyclines exhibit similar antimicrobial activity, and cross-resistance is common. Resistance has reduced their usefulness in the recent years, and another major restriction is the contraindication for use in children younger than 8 years old, as well as pregnant women. If used, again, in children or pregnant women, the drug may permanently stain the teeth. The severity of staining is determined by the timing, the duration, and the form of tetracycline administered. So let's look at the mechanism of action. The basic tetracycline structure is a hydronephrescence nucleus that contains 4 fixed 6-carbon rings. The tetracyclines differ in the terms of substitutions on the 5th, 6th, and 7th position of the basic tetracycline structure. I do not expect you to know this, however, it's good just to have a background. These substitutions affect lipid solubility, serum half-life, and the effect that food has on bioavailability of the drug. They inhibit protein synthesis. A little difference in microbial activity has been noted between the different tetracyclines. They are a wide-spectrum antibiotic that are useful for empirical therapy. They are one of the first drugs of choice for acute bacterial exacerbation of COPD, chlamydia, and rickettsial infections. And they provide a second-line consideration for many other infections, especially in patients with allergies to other antibiotics. The choice between tetracyclines is made by determination of the drug characteristics. Doxycycline and minocycline are the 2 most commonly used tetracyclines. Most of these must be taken with milk or antacids. However, minocycline and doxycycline do not have this complicating factor, so it is easier to get the patient to take them correctly. I'm sorry, I hope I said most tetracyclines must not be taken with milk or antacids, other than minocycline and doxycycline. Also, doxycycline has a longer half-life than tetracycline and produces less gastrointestinal disturbances than the other tetracyclines. Although many of the tetracyclines, along with doxycycline, can cause diarrhea. Overall, doxycycline is the most useful of all the tetracyclines in primary care, and again, imperative that the pregnant woman woman does not take this medication. There are non-antibiotic actions of tetracyclines, which results in an anti-inflammatory process and immune suppression, inhibition of lipase and cholinesterase, enhancement of gingival fibroblastic cell attachment, and wound healing. So again, we need to look at patient variables. In the geriatric patient, tetracyclines are well absorbed, even in patients with low gastric pH. With the exception of doxy and minocycline, serum levels of tetracycline are increased by impaired renal function, and dosages do need to be reduced in the elderly. Because the primary routes of excretion with doxycycline and minocycline are biliary, and the serum half-life of these agents is unaffected by renal insufficiency, either doxy or minocycline would be a good choice of tetracycline in the elderly patient, particularly if the patient has deteriorating renal function. In pediatrics, tetracyclines should not be given to children younger than 8 years old, again, due to the permanent damage to teeth and bone. Pregnancy and lactation, this is a category D. Tetracyclines do cross the placenta. Because of the chelating effect, they bind with calcium, resulting in discoloration of the teeth, enamel, hypoplasia, and inhibition of fetal skeletal growth. The period of greatest risk of discoloration of the teeth ranges from the middle of the second trimester up to 6 months of age in the newborn. Tetracyclines should never be given to pregnant patients. Relatively high concentrations of tetracycline have been shown to be excreted in the breast milk. Therefore, again, these agents are contraindicated during lactation. For women, tetracyclines may decrease the pharmacological effects of oral contraceptives. Breakthrough bleeding or pregnancy may occur, and it's suggested that an alternative form of contraception as backup protection during antibiotic therapy is suggested to the woman. For patient education, all tetracycline should be taken with the patient sitting upright with a full glass of water, at least 240 ml, to avoid esophagitis or esophageal ulceration. The patient should not lie down for approximately 1/2 hour after taking each dose, because reported cases of esophageal ulceration involve patients lying down immediately after taking the medication. All tetracyclines, with the exception of doxy and minocycline, should be taken on an empty stomach 1 hour before or 2 hours after meals to maximize their absorption. Again, with the exception of doxy and minocycline, they should be taking the use of iron preparations, antacid products, or other products that contain aluminum, magnesium, calcium, zinc, and milk products should be avoided, since they substantially decrease absorption via the oral administration. Because of the potential for tetracycline induced photosensitivity, the patient should avoid unnecessary exposure to the sun. If sun exposure is unavoidable, sunscreens with a minimum SPF of 30 should be used. Finally, doxycycline has been associated with less nephrotoxicity than other tetracyclines, and even though associated renal failure has been reported, doxy would be the safer medication to use. Tetracyclines can cause esophagitis. Patients should report any symptoms of hepatotoxicity, such as persistent nausea, vomiting, anorexia, or yellow coloring of the skin, eyes, dark urine or pale stools, and should stop taking the medication immediately. Next, we will look at the macrolides. Macrolids include erythromycin, azithromycin, and claromycin. These are commonly used in primary care. They have primary indications and are used as an alternative to penicillin-sensitive patients. Erythromycin is active against most pneumococcal and group A beta hemolytic streptococci and is useful for atypical infections such as Legionella, pneumophilia, mycoplasma, pneumonia, Corynebacterium, diphtheria, Chlamydia trichomonas, Listeria monocytogenes, Uroplasma, and some Rickettsia infections. Susceptible gram-negative bacteria, including Bordetella, pertussis, Neisseria, gonorrhea, and meningitis, have also been found. The keteloid macrolid was approved in 2004. A new drug, difexamycin, entered the market in 2011 and is indicated for C. diff diarrhea. However, a major limitation of this drug is the frequent occurrence of GI side effects and drug interactions. Azithromycin, however, and claromycin rarely cause problematic GI effects. The macrolids affect the cytochrome P450-3A4 system and inhibit metabolism of certain drugs. A careful patient history of concurrent medications will aid in preventing adverse drug reactions, and you should always run a program to look at drug reactions of your patients with these medications. There are many out there. Hippocrates has a drug interaction program in which you can put the patient's drugs into the program and then run it against or the macrolids or any other drug as well. So the macrolids indications used mostly for otitis media, acute bronchitis or pneumonia in the patient with COPD, community-acquired pneumonia, pharyngitis, and sinusitis. A lot of you may know this drug as in which we use a Z-Pack, in which the patient takes 2 tablets the first day and 1 tablet daily for 4 more days, and the medication stays in their system for 10 days. Allergies do occur. Reactions include skin rash, fever, eosinophilia, hepatitis, cholestatic hepatitis, which occurs rarely, but most often with the estolate compound. It may be an allergic reaction to that compound. There is some resistance. The macrolid use has increased, and resistance has increased as well. The 3 major mechanisms of resistance to the macrolids include decreased permeability to the cell wall of the macrolids. Some bacteria are able to pump the antibiotic out. A second mechanism, target site alterations, result from a genetic ability to decrease binding of the antibiotic to targets on the ribosomes. This decreased binding confers a high degree of resistance. The third major mechanism of drug inactivation is by enzymes. The use of macrolids increases the nasopharyngeal presence of macrolid and penicillin-resistant pneumococci. Macrolid-resistant streptococcus is also a problem in the treatment of community-acquired pneumonia and middle ear infections. About half the patients with macrolid-resistant infections have not taken the antibiotics in the past 6 months. Group A strep, common in strep throat resistance, is increasing to up to 15 to 35% in some geographical areas. Streptococcus pyogenes, Staphylococcus aureus, Streptococcus viridans, Clostridium, and Haemophilus influenza are developing increased resistance of the macrolides. Many patients do like taking this medication because, again, with the Z-Pak, it's only a 5-day course, which stays in the system for 10 days. Again, the mechanism of actions, they inhibit protein synthesis. The macrolides consist of a large lactone ring in which sugars are attached. Structural modifications in Claromycin and Azithromycin make them more acid stable, which improve tissue penetration and broaden the spectrum. Macrolides may be bacteriostatic or bactericidal. The mechanism of action involves inhibition of protein synthesis that results from binding specifically to the 5-OS ribosomal subunit. This causes the RNA to dissociate from the ribosome and prevents protein synthesis. Macrolides inhibit a specific step in protein synthesis where new tRNA moves from the ribosome to the new site. Some macrolides block protein synthesis by binding to a specific location of the RNA on the 5-OS ribosome. Other effects of the macrolides occur in the gastrointestinal stimulation. They also appear to modulate inflammation by inhibiting production of the cytokine interleukin 8. In addition, the macrolides may be used as prokinetic agents in hospitalized patients. Treatment principles. These medications are often used as alternatives to penicillin. Patients who are unable to take penicillin, most practitioners consider the macrolides to be a safe first-line choice for patients with uncomplicated infections. Erythromycin products are relatively inexpensive. However, the newer macrolides are more expensive. When a macrolide is prescribed, caution should be taken with dosing in the presence of severe renal or hepatic impairment or when potential drug interactions with the patient's current drug regimen is identified. Erythromycin is a first-choice drug for the treatment of children with pneumonia ages 3 months to 5 years or ophthalmia neonatorium. Erythromycin is an alternative treatment for impetigo, cellulitis, otitis media, pharyngitis, chlamydia, and Lyme disease in children. It also provides alternative treatment for the prevention of bacterial endocarditis in patients allergic to penicillin. Azithromycin is another first-choice drug for the treatment of pneumonia in children ages 6 months to 5 years and older. It's the first choice of treatment for chlamydia in adults and used alternative treatment for patients with impetigo, cellulitis, sinusitis, pharyngitis, acute exacerbations of COPD, and traveler's diarrhea. Claromycin is used in adults for pharyngitis, sinusitis, otitis media, acute exacerbation of COPD, pneumonia, and skin infections. Erythromycin must be taken 3 or 4 times a day. This makes it very difficult. Azithromycin offers the advantage of once daily dosage, and Claromycin requires twice daily dosage. The major difference between the erythromycin and the newer macrolides include the GI tolerability, a broader spectrum of activity, and dosing frequency. The longer drug action of azithromycin can make a critical difference in patients' adherence. It's much easier to take a medication once a day rather than 4 times a day, or even twice a day. The strength of each erythromycin product is expressed as erythromycin-based equivalents. As a result of differences in absorption and biotransformation, varying quantities of each erythromycin salt form are required to produce the same free erythromycin serum levels. Erythromycin is acid labile and usually is formulated in enteric or film-coated forms for oral administration. Acid-stable salts and esters are well absorbed. These include the estellates, ethyl succinate, and stearate. Again, the macrolides are active primarily against gram-positive organisms, including S. pyogenes, GABHS, and Streptococcus pneumonia. The newer macrolides have added effectiveness against gram-negative bacteria and anaerobes. Macrolides are of value for their unique ability to treat atypical pathogens such as pneumonia, which can be seen in community-acquired pneumonia. Erythromycin and claromycin have significantly increased potency against gram-negative bacteria and anaerobes, and generally are reserved for the more complicated infections such as community-acquired pneumonia and exacerbation of COPD, as well as sinusitis. Fidaxomicin is not appropriate for systemic infections. Its similar safety profile to vancomycin with higher response rate after a 10-day course of treatment. In geriatric patients, lower doses of macrolides generally are not necessary, provided that they do not have severe hepatic or renal impairment. It's necessary to check renal and hepatic function before beginning the treatment with this drug. In pediatrics, age, weight, and severity of illness are important factors in determining the dosages of children when erythromycin, azithromycin, or claromycin are prescribed. Erythromycin is considered a category B. Erythromycin estellate has been associated with elevated liver function tests in 10% of pregnant women and should be used cautiously in pregnancy. Azithromycin is considered category B, and claromycin is considered category C. These drugs should not be used in pregnancy except in clinical circumstances where no alternative is available. Erythromycin is considered compatible with breastfeeding. However, the drug is transferred via breast milk, and the nursing woman should be aware that the nursing child will be exposed to this drug as well. Azithromycin and claromycin may be excreted in the breast milk, and caution should be exercised when these drugs are administered to a nursing woman. For patient education, you must stress the fact that the patient should not chew, cut, or crush the tablets. They're very irritating to the GI tract. Most erythromycin products should be taken with food. Claromycin may be taken with or without, and azithromycin can be taken without regard to food. The oral suspension, however, should be given on an empty stomach. Claromycin suspension should not be refrigerated and be shaken very well before use. Patients who use oral contraceptive for birth control should be advised that macrolides can reduce their efficacy and that they should consider using a backup method for contraception. And the more advanced macrolides, visual disturbances may occur, particularly in delay in accommodation. Pseudomembranous colitis has been seen, and these agents has the potential to prolong the QT interval on EKG, which makes patients at risk for ventricular arrhythmias. Myasthenia gravis may be exacerbated on patients taking the newer macrolides. So let's move on to the fluoroquinolones. The quinolones were discovered in 1962 as a byproduct of chloroquine synthesis. And the earliest drugs were called quinolones. Later, a fluorine radical was added, and these newer drugs were called fluoroquinolones to distinguish them from the earlier drugs. The fluoroquinolones are a group of potent antibiotics with a wide spectrum of action against gram-positive and gram-negative organisms. The primary care environment should be familiar with the use of ciprofloxacin, moxifloxacin, and levofloxacin. The fluoroquinolones have a good safety profile and excellent absorption after oral administration. Side effects do occur. Headache and dizziness occur in 11% of the patients and are most commonly reported as adverse events. The newer fluoroquinolones offer expanded coverage of gram-positive pathogens, and moxifloxacin is active against anaerobes. Some of the fluoroquinolones, 3 of the fluoroquinolones introduced in the early 2000 or 2001 has been taken off the market due to adverse events. The quinolones are active against aerobic gram-negative bacilli, especially the enterobacteria, Haemophilus, and gram-negative cocci, such as Neisseria and Moraxella catarrhalis. They are active against Staphylococcus and Mycoplasma. Ciprofloxacin and levofloxacin are the only quinolones active against Pseudomonas. So what are the quinolones used for? Their indications include lower respiratory infections, skin and skin structure infections, bone and joint infections, infectious diarrhea, sexually transmitted diseases, complicated urinary tract infections, prostatitis, otitis media, otitis externa, conjunctivitis, corneal ulcers, and corneal ulcers. Allergies, allergic reactions occur in 0.5 to 3% of patients. Rashes are the most common allergic reaction. The newest fluoroquinolone, gemafloxacin, causes rashes in about 14% of young women. More serious reactions include anaphylaxis, drug fever, vasculitis, interstitial nephritis, and serum sickness. Have been known to occur but are uncommon. Resistance occurs by mutation. No quinolone modifying abilities have been seen in bacteria. However, spontaneous mutations that result in resistance alter the target enzymes or alter the drug transport across the cell wall. Plasmid-mediated quinolone resistance has been seen. These mutations produce efflux pumps to remove the antibiotic from the cell. Pseudomonas and Staphylococci are the most two troublesome bacteria. More recently, resistance to Neisseria, gonorrhea, Campylobacter, and E. coli has been noted. Underdosing caused by failure to finish the prescription course should be avoided to prevent this resistance from occurring. Mechanism of action. Quinolones have a dual ring structure. Substitutions on the dual ring determines the type of quinolone. Ofloxacin is a racemic mixture, i.e. the right and left-handed molecules that contains the active ingredient levofloxacin. The mechanism of action is inhibition of deoxyribonucleic acid, and the enzyme that is essential in the transcription, replication, and repair of bacterial DNA. The blocking of DNA gyrase that occurs in concentrations of 0.1 to 10 grams per mil promotes superhelical formation of bacterial DNA, resulting in destruction of DNA. Again, you do not have to know this. However, you should be exposed and have a general idea of how these medications work. So let's move on to patient variables. In geriatrics, elderly patients are more likely than others to have reduced renal function, which increases the half-life of the fluoroquinolone. These dosages must be adjusted in patients with impaired renal function. Also, older adults are more prone to develop tendon rupture and adverse CNS reactions with the quinolones. Systemic quinolones, including ciprofloxacin, should be used in caution in patients with CNS disorders such as seizures or cerebrovascular disease such as cerebral arteriosclerosis that may predispose these patients to seizure or a lower seizure threshold. They also should be used in caution in the presence of other risk factors that may predispose patients to seizures or lower the seizure threshold, such as certain drug therapy or renal impairment. The quinolone should be systemic quinolone should be avoided, such as ciprofloxacin in patients with a history of myasthenia gravis. Quinolones may exacerbate the signs of the disease and lead to life-threatening weaknesses of the respiratory muscles. Serious post-marketing events such as deaths and the requirement for event support has been associated with quinolone in patients with this disease. In pediatrics, caution should be used when prescribing systemic ciprofloxacin in children and adolescents up to 18 years of age for infections not listed in the approved labeling. According to the manufacturer, an increased incidence of adverse reactions compared with controls, including events related to joints or surrounding tissues, has been noted. The incidence of musculoskeletal and neurologic adverse reactions has been evaluated, and for ciprofloxacin in the treatment of complicated UTIs or pyelonephritis in children 1 to 17 years. Adverse events were evaluated in a comprehensive fashion. Although the overall incidence of adverse events compared the drug within 6 weeks were 41% for ciprofloxacin versus 31% in a comparable group. Severe adverse events were observed in 7.5% of ciprofloxacin patients. Ofloxacin and ciprofloxacin are the drugs that have been commonly used in children, and ciprofloxacin has been approved by the FDA for treatment of patients with UTIs, including pyelonephritis. In pregnancy and lactation, it's a category C. No adequate studies have been conducted. Use during pregnancy only if the potential benefit justifies the potential risk to the fetus. Fluoroquinolones do reach the breast milk concentrations equal to the serum levels within 2 hours of administration. Because of the association of fluoroquinolones with articular damage, these agents are not recommended for use in nursing mothers. Again, even though the fluoroquinolones are metabolized in the liver, the elimination does depend on the renal function. Fluoroquinolones are excreted primarily through the renal system, and adjustment of doses needs to be made with patients with impaired renal function. For patient education, the patient should be instructed to drink plenty of fluids while taking this product. Norfloxacin should be taken on an empty stomach. Cipro and levofloxacin tablets can be taken without regard to meals. Levofloxacin solution should be taken on an empty stomach, however. Fluoroquinolone should not be taken with milk, antacids, iron preparations, or any products that contain aluminum, magnesium, calcium, iron, or zinc. Sulfate, an aluminum salt of a sulfated glyceride, also should be avoided. Absorption of the fluoroquinolones can be reduced as much as 98% by chelation. For this reason, the drug should be taken at least 2 hours before or 6 hours after divalent or trivalent cations containing products are given. Caution should be used when driving or operating machinery or performing any task that requires attentiveness, because the fluoroquinolones can cause dizziness, drowsiness, or confusion. This is often seen in the elderly. Again, with this drug, you need to avoid undue exposure to the sun or use sunscreens greater than a 30 SPF to prevent the occurrence of photosensitivity reaction. We'll now move on to the Immuno of Glucosides. Immunoglucosides are generally reserved for the treatment of patients with severe gram-negative infections that are resistant to many of the other antibiotics. They normally are not used in primary care, but are important antibiotics, and you should be at least familiar with their use. They're more potent than other antibiotics and are used for systemically serious infections. They have a very narrow therapeutic window, so careful dosing based on the pharmacokinetics of the drug is necessary. These agents are associated with significant nephrotoxicity, ototoxicity, and neuromuscular blockade. So caution needs to be used with these medications. Immunoglucosides interact with the beta-lactam antibiotics, destroying the beta-lactam ring, an amino group that renders both antibiotics inactive. They are excreted renally, so patients with impaired renal functions are at increased risk for toxicity. Their use in treatment of infections is either IV or IM. Oral aminoglucosides are not absorbed. Their only use is for suppression of intestinal bacteria in GI preoperative surgical preparation. Aminoglucosides are used extensively in topical preparations. Topical aminoglucosides for localized treatment of eye, skin, ear, etc. There are 9 aminoglucosides available in the United States, and they were derived from soil actinomyces bacterium that have been systemically screened for antimicrobials. Gentamicin is a mixture of 3 closely related constituents. So what are their indications? Orally, they're only indicated for the suppression of oral bacterial flora. This is often used preoperatively. Topically, they're used for irrigation of infected wounds, and parenterally, they're used for complicated UTIs, complicated respiratory infections, skin, bone, and soft tissue infections, CNS infections, GI infections, such as peritonitis, and are effective against organisms such as Enterobacter, E. coli, Klebsiella, Proteus, Pseudomonas, Serrata, Staphylococcus aureus, Pseudomonas, and Streptomycin, and is also effective against Mycobacterium. So again, aminoglycosides are reserved for treatment of serious resistant gram-negative infections, not normally used in primary care, but you must at least be familiar with the use. It has a very narrow window and is associated with nephrotoxicity, ototoxicity, and neuromuscular blockade. They interact with the beta-lactam antibiotics, rendering both antibiotics ineffective. Patients with impaired renal function are at increased risk for toxicity, and oral aminoglycosides are not absorbed. These are only used for suppression of intestinal bacteria. These are mostly used in hospitalized patients, either intramuscularly or intravenously for treatment of severe infections. They are used topically for localized treatment of eye, skin, and ear infections. Allergic reactions do occur, but they are rare. Many include anaphylaxis, toxic epidermal necrolysis, erythema multiforme, and Stevens-Johnson syndrome. Resistance is rare due to its minimal use, but can occur through enzymatic inactivation. Mutations can result in resistance, such as resistance to Mycobacterium, tuberculosis, to streptomycin. A mutation has allowed many E. coli to become resistant. Resistance may also result from decreased drug uptake or efflux pump activity. Mechanism of action. Aminoglucosides have a six-membered ring with amino group substances. The aminoglucosides refers to the glucosidic bonds between the ring and amino-containing sugars. Aminoglucosides are bactericidal that strongly and irreversibly bind to the 30S subunit of bacterial ribosomes, blocking the recognition step in protein synthesis and causing misreading of the genetic code. The ribosomes separate from messenger RNA and cell death ensues. Again, oral use only for the suppression of bacterial flora and the treatment of patients with hepatic coma. Topical use, aminoglucosides have a wide variety of use. Clinically significant serum levels have occurred following topical use. For surgical procedures, as in gut sterilization, irreversible deafness or renal failure may result from extremely high concentrations in the blood. Death may recur as a result of neuromuscular blockade following irrigation of small and large surgical fields with the aminoglucoside preparation. You should consider potential toxicity when ordering aminoglucosides when irrigating a wound. The parental use, these medications are reserved for short-term treatment, less than 10 to 14 days, for patients with serious infections caused by susceptible strains of gram-negative bacteria. This is to minimize the risk of toxicity. Bacteriologic studies should be performed to identify the causative organisms and their susceptibilities to the specific aminoglucoside. They may be considered as initial treatment for patients with suspected gram-negative infection, and therapy may be instituted before the results of susceptibility testing is obtained. These are the very sick patients that are admitted to the hospital. Clinical trials have demonstrated that some of these products are ineffective in infections caused by gentamicin and or tobramycin-resistant strains of gram-negative organisms. The decision to continue therapy along with a particular drug should be based on the results of susceptibility tests, the severity of the infection, the response of the patient, and the important additional considerations as of the patient's state of hydration, renal status, and other medications that the patient may be taking. To monitor these medications, the serum peak, which is drawn approximately 30 to 45 minutes after IV dosing, or 60 minutes after intramuscular dosing, and the trough drawn immediately before dosing should be monitored after the second or third dose and every 3 to 4 days thereafter for the duration of therapy. You should monitor the serum calcium, magnesium, and sodium of these patients and test the 8th cranial nerve function by serial audiometric testing. Hearing losses in the high frequency range can occur. You should monitor creatinine BUN, collect urine specimens for examination during these therapies, as well as blood levels. Patient variables. In geriatrics, diminished GFR related to aging, they prolong the drug's half-life and increase the risk of toxicity. In pediatrics, premature infants and neonates have immature renal systems, and this also results in prolonged half-life. In pregnancy and lactation, gentamicin, tobramycin, and amikacin are considered category C. However, the neomycin, streptomycin, and kanamycin are considered category D, not to be used. The immunoglucosides do cross the placenta, but the distribution to the breast milk is unknown. For patient education, it's necessary to monitor the blood values during the therapy to make sure that it's effective and prevent any toxicity. If any visual, hearing, or urinary problems occur, the healthcare provider should be contacted immediately. The medication should be discontinued if tinnitus or subjective hearing loss occurs. When intramuscular injections are given, the injection site may be uncomfortable, and warm, moist heat and mild analgesics may reduce this localized pain. So let's move on to the sulfa drugs, sulfamides. The sulfamides have a wide antibacterial spectrum that includes both gram-positive and gram-negative organisms. They're most commonly used for urinary tract infections. Sulfamide therapy continues to have a place in the treatment of prophylaxis for specific clinical conditions such as pneumocystis, pneumonia, toxoplasmosis, typhoid fever, pertussis, nocardiosis, and listeriosis. Strains of community-acquired methicillin-resistant Staphylococcus aureus have emerged as an important group of pathogens. The sulfamides and tetracycline antibiotics remain valuable low-cost agents for use with most of these soft tissue and skin infections. They are short to medium acting. They're active in the gut and can be used topically. Frequent allergic reactions and drug resistance limit the more extensive use of sulfamides. Sulfamethoxazole is combined with trimethoprim, and this is a common drug named Bactrim, and it's used for the synergistic effect, and is most commonly used sulfamide. Silver sulfidine is a frequently used or topical agent used in wound infections as well as burns. The sulfamides are divided into 4 classes. 2 are systemic antibiotics, short and long-acting, for topical infections and bowel problems. Short-acting agents are rapidly absorbed and rapidly eliminated. However, the long-acting agents are rapidly absorbed but excreted slowly. No long-acting sulfamides are currently available in the United States because of associated toxicity, especially in seen as Stevens-Johnson syndrome. Poorly absorbed sulfamides are used to treat infections of the bowel and prepare individuals for surgery as well. Topicals include sulfamides that are not absorbed systemically. These are used topically, particularly in the eye and ear. And the first sulfamide was used in 1932 against streptococcal infection. Indications include urinary tract infections, acute exacerbations of COPD, pneumonia, traveler's diarrhea, diverticulitis, and sinusitis. Allergies do occur. Sulfamide or sulfur allergy is fairly common, occurring in about 6% of the population. Allergic reactions are divided into type 1, immediate hypersensitivity, and type 2 to 4, IgG and IgM antibodies and T-cell mediated. Allergies occur to sulfamide metabolites at the N1 and N4 amino nitrogen on the heterocyclic ring, and only antibiotic sulfamide drugs have this structure. Non-antibiotic sulfamide drugs do not contain this structure. There has been some concern about cross-allergy with other drugs that contain the sulfamide group, but research has shown that this does not occur. Resistance it's a random mutation. It becomes a common problem that limits the usefulness. Streptococci, Staphylococci, Enterobacter, Neisseria, and Pseudomonas are resistant. A single mechanism of resistance, random mutation, which results in the overproduction of para-aminobenzoic acid or structural changes in the enzyme occurs. Transfer of resistance occurs through plasmids. Plasmid-mediated resistance has become more common, especially with the trimethoprim. Resistance also is decreased by bacterial permeability. Again, the type 1 allergic reaction is an immediate sensitivity reaction which includes anaphylaxis, urticaria, angioedema, and hypotension. This usually occurs within 30 minutes of taking the medication. Type 2, on the other hand, is a hypersensitivity or cytotoxic reaction which causes hemolytic anemias, neutropenias, thrombocytopenias, and vascular tides, which generally become apparent in 7 to 14 days of administration. There is a type 3 hypersensitivity reaction which affects entire organs. Skin, joints, and kidneys are often affected. And the classic serum sickness syndrome, fever, vasculitis, lymphedema, lymphadenopathy, rashes, and urticaria is also included in this category. These symptoms occur days to weeks after initiation of administration. And finally, type 4, cell-mediated or delayed hypersensitivity is mediated by cytokines released by T cells. Maculopapular rashes, Stevens-Johnson syndrome, and toxic epidermal necrolysis are examples of the type 4 sensitivity. These conditions usually take about 48 to 72 hours after administration for these to develop. Spectrum of activities. Sulfamides are derived from sulfonamide, which is a structure similar to that of the PABA. This is necessary for bacteria to produce folic acid. The sulfamides exert bacteriostatic activity. These are competitive antagonists that inhibit the enzyme responsible for the utilization of the PABA in the synthesis of folic acid. These mechanisms prevent reproduction of bacteria that synthesize the folic acid. Those bacteria that do not require folic acid and those that can use folic acid absorbed by the GI tract are unaffected by sulfamides. They are active against the gram-positive, many of the gram-negatives bacteria, and are most commonly used in urinary tract infections. We need to look at patient variables. In geriatric patients, the use of Bactrim in the elderly results in an increased risk for of severe reactions, especially when used in conjunction with other drugs or in those patients with renal or liver impairment. The most frequently reported severe adverse reaction in the elderly includes skin reactions, bone marrow depression, and decreased platelets, with or without purpurea. The elderly patient who has taken certain diuretics, especially the thiazides, may have an increased incidence of thrombocytopenia with purpura. In pediatric patients, there is limited data available on the safety of repeated courses of Bactrim in children younger than 2 months, and sulfamides are not recommended in children younger than 2 months of age. There's a growing history of child allergies to this product. In women, it's considered category CD. You do not use this at term because Bactrim may interfere with the folic acid metabolism. Used during pregnancy only if the potential benefit outweighs the potential hazards to the fetus. Although it's not the first-line therapy for asymptomatic bacteria or cystitis, Bactrim can be used during the second trimester, but again, not the third trimester or at term. It is excreted in the breast milk, so caution is used when treating the mother. Patient education. Patients should be instructed to drink 1 8-ounce glass of water with each dose and several times a day to prevent crystal formation in the urine. The medication should be taken on an empty stomach with a full glass of water, and patients should avoid exposure to sunlight due to photosensitivity. Patients need to notify their provider if they develop hematuria, rash, tinnitus, dyspnea, fever, chills, or sore throat. For patients taking the oral suspension, the product should be shaken well and refrigerated upon opening.